I'd like to say good morning because we originally scheduled this for 10 a.m., but good afternoon. Welcome to the National Press Club. My name's Jamie Horwitz. I help guide the Headliners Committee here at the club, and on behalf of the 3,000 members of the Press Club and our president, Jeff Ballou, I want to welcome you here today, and I want to welcome our guests. Before we get into introductions of our speakers, I haven't really done this before. I chaired the Headliners Committee for the past couple years prior to when we made it the Newsmaker Committee before we made it the Headliners Committee. And I've really never talked about the process of how we select something to be either a newsmaker or a headliner. And it seems like before we had the hurricanes and the earthquakes, the national disaster we were talking about was the opioid crisis. And as the calendar goes, it wasn't that long ago, but in some ways it seems like a while ago. And we thought that it would be important this particular week when we thought Congress would be dealing with the budget to talk about this, because how can you take on this disaster and when there was actually talk that maybe the government would shut down? How would this all work? And so that was our sense when we started this process, and we reached out to the IAM and the National Union of Healthcare Workers to try to get frontline healthcare workers, because we wanted people that were actually dealing with the opioid crisis and mental health, and we wanted to find somebody in Congress that could talk about the other side of the coin, about how these things would be funded and what was on the table, because at the same time, it wasn't all that long ago that we heard that the administration was making cuts to programs related to mental health in their proposed budget. Little did we expect that this week would become a healthcare week. And so it seems like we have a lot to talk about today: opioid crisis, healthcare, funding. And so the panel that we put together, we think, is truly an excellent panel to discuss this. To a certain degree, we're going to try to take this from birth through later years. Our first speaker is going to be Jackie Schalit, who works with newborn babies and children in Oakland, who and I'll let her go into more detail of what she does and where she works. But she's right at the beginning. On the far end over here, Cuyler Costanzo works with a population where the average person he's treating is 23 years of age in Akron, Ohio. And Ken Rogers is from Sacramento, California, and he deals with an adult population that I would think probably goes considerably older than what I've just mentioned. And last, but certainly not least, is Congressman Tim Ryan from Ohio, who represents the 13th Congressional District in Ohio. And in addition to his leadership as the co-chair of the House's Addiction Treatment and Recovery Caucus, the congressman also co-chairs the Military Mental Health Caucus, and I believe serves on the Mental Health Caucus, correct? And so, having said that, to save time, I think what we'll do is we'll start with Jackie, and then rather than me coming back to introduce each person individually, we'll just take one after the other. And Jackie, if you wouldn't mind coming up to the microphone, please. Thanks. And if I could just say one thing, after each person speaks for a few minutes, at the end we'll take questions for about a half hour.
Okay, well, hello everybody. I'm so happy to be here today. My name is Jackie Schalit. I'm a parent-child therapist with UCSF Benioff Children's Hospital, Oakland. For the past 15 years, I've had the privilege of working on the FIRST team. The FIRST team specializes in working with little babies birth to 7 who've been impacted by incarceration and substance abuse. I'm here today for the babies, for the families that I serve that are struggling with mental health and substance abuse. I came across a statistic that just shocked me, and I imagine it'll shock you too. Based on data from the combined 2009-2014 national surveys on drug use and health, about 1 in 8 children are living in a home where at least one parent is a substance abuser. That's 8.7 million children. The hardest hit were the little ones, birth to 2, with the largest population. So infants and young children are the most vulnerable in our population, and they're often the collateral damage of addiction. We know from the ACEs study that came out of Kaiser that adverse childhood experiences greatly impact adults and children as they grow up, and they have long-term health issues. When a child grows up in a home where someone is using drugs, their trauma is stacked up against them. And we need to intervene quickly and swiftly to make an impact. I want to tell you about a mother that I have treated in the past. She came to us with a 2-month-old little baby. Her baby was fussy and difficult to soothe. He had a rough life. His first month was spent while she was actively using drugs, so it was chaotic and difficult for him, thus increased his fussiness. When she came to my office, or when I came into her home, she began to tell me that she too was a fussy baby, and her parents were addicted. So she didn't know any better. She fell into the same patterns that her parents did, but she wanted different for her little baby. She knew she needed help, and she was lucky enough to get into our program, and she was given the support that she needed. Her little baby was given support. So now her little boy is 2. He is feisty, he is strong, and he feels safe with his mother. His mother is in recovery and doing well. So this is a story of hope. This family got the treatment that they deserved, but it took long, steady treatment and support. Sadly, this isn't always the case. I'm from the Bay Area, one of the wealthiest areas in our country, and our county mental health system and substance abuse system is a disaster. It's overburdened, and it's just inadequate. The other day, right before I came here, I spent hours on the phone with a young father with a 1-year-old baby I was treating. He had a heroin addiction and wanted to get help. He wanted to change his life, so he was on methadone. I called for hours and hours trying to find a treatment program for him. And each person on the other line said, nope, we don't take folks on methadone. I finally found one place in Alameda County that would take him, but guess what? The line was a month long. And plus they said he would have to detox from the methadone. Now, to me, that makes no sense, right? We have a father who wants to get help, and he wants to change his life for the better, but there's no access to treatment. We can do better for the kids, and we can do better for the families. So I'm here to tell you, after 15 years, over 15 years working in the field, I have never met a baby that doesn't love their parent, despite all they've gone through. And I've never met a parent who's struggling with addiction that doesn't want different for their baby. They know that this is a painful, grueling process, and they want to change the patterns in their family. So I'm here to say that we can all do better. The kids deserve better, and the families deserve better. Thank you so much for your time.
Hi, everyone. Thank you for coming out this afternoon. My name is Cuyler Costanzo, and I'm with Oriana House in Akron, Ohio. I serve as the clinical coordinator there of our treatment services. I oversee treatment over in Akron. That's our home office, but we just recently opened up a halfway house and a Rigel recovery center in Marietta, Ohio. Oriana House, we're a nonprofit community corrections agency that also treats our clients for substance use disorders. We are also an approved medically assisted treatment agency, and the MAT that we are approved to provide is Vivitrol, and that Vivitrol is a non-opioid MAT, and we've seen some pretty good successes with that. And what the Vivitrol does, it treats the opiate addict's physical cravings, so it reduces that. So we then can, put together a treatment plan where we can then, unpack the psychological things that they're dealing with, in counseling. So we apply both those at the same time. We also have other locations, not only in Akron and in Marietta, but we're also in Cleveland, Tiffin, Fremont, and Sandusky. Most of my client population, they're individuals that have been sentenced for substance related charges, whether it was, possession charges, selling to support their habit, so that would be a trafficking charge, operating vehicles under the influence. Other things could be domestic violence, robbery and stuff like that. So when, about 65 to 70% of our clients that we see have an opiate use diagnosis, and the average age, like Jamie was saying, is 23 years of age. So these are young individuals, and these are good people. They're from good families, okay, but they've fallen in the throes of addiction, and these clients of ours, they have value. So why am I here today? I'm here to address, our nation's opiate epidemic. This epidemic is a national crisis. It affects everyone. There's probably everyone in this room has been affected one way or another. Maybe you know somebody, a family member, a coworker, a friend. It affects everybody. Nationally, let's take a look at some statistics. In 2015, there was 52,000 overdoses that resulted in death. 52,000. Okay. In 2016, it increased to 64,000. That's a 23% increase. Huge increase with this epidemic. Now in my home state of Ohio, okay, we're at ground zero. Okay, in 2015, okay, we had 3,050 overdoses that resulted in death. In 2016, it increased to 4,150. That's a 36% increase. Okay, so it's out there, and it's affecting a lot of people. It's affecting families. It's children, employers. So it is a national crisis. When I was coming out here, waiting to board the plane Saturday, picked up the Akron Beacon Journal, and on the front page it reported that in Akron, and the city of Akron's about 190,000 people, we had 58 overdoses. They didn't result in death, but we had 58 overdoses. It was probably higher than that because, we're pretty good in the Summit County area. In 1 week, yes, thank you. Yes, in 1 week. But it was probably higher than that because, we're pretty good about getting the Narcan out to the families that their loved ones are afflicted with this disorder here. So some of those were probably brought back by the Narcan and was not reported to the in that number there. You may have also read in a recent article with the Cincinnati Enquirer that in 1 week, they had 18 overdoses that resulted in death down in the Cincinnati and surrounding area. They had 180 overdoses that didn't, but 180 people in 1 week. And then there was 200 opiate uses that resulted in arrest, where they either passed out in their car or in a bathroom or driving. Whatever, there was a possession charge and they were incarcerated in one of the local jails. 200 in 1 week. And the saddest thing is the innocent, the babies. In that 1 week, there was 15 babies born that were that had opiate related medical concerns going on. 15 just in that 1 week. So most of the clients that I treat that get to me, they pretty much have lost everything by the time they get to us. Okay, they lost their job, they've lost their insurance, their family, housing, esteem, And, with the ACA and the expansion of Medicaid in the state of Ohio, this has really helped our clients to, get the treatment services that they need. Okay, without the Medicaid expansion and the ACA, we wouldn't be able to help them, So, but even with the expansion of the Medicaid and even with the ACA, we're still strapped. We're overwhelmed. We don't have enough staff. We don't have enough facilities. It's just the growth of this epidemic. It's alarming. So in closing, I am concerned that if the ACA is repealed, and if there is a cut in Medicaid, a lot of my clients, a lot of good Americans, they're going to continue to suffer and they're going to die. So thank you.
Good afternoon. Thank you. My name is Kenneth Rogers, and I'm a psychologist working for the Permanente Medical Group in Northern California, specifically in the Sacramento area. I also serve as the vice president on the executive board of the National Union of Healthcare Workers, and so my comments today will reflect partially my personal experience working with patients, but also the experience of my colleagues who I represent. I've come to speak to you today about how the opioid crisis is personal to the work I do, as well as the consequences of failing to provide full mental health parity. While not all the patients I work with have some sort of opioid addiction, those who do have serious underlying mental health issues. Opioids, by their very nature, are pain relievers, and the people I work with are in pain. They're anxious, depressed, and they've reported turning to opioids to deal with this pain. This solution comes at a cost. When people turn to opioids, they miss out on family celebrations, gatherings with friends, church events, and most importantly, work. This report is supported by national findings from a recent Brookings Institute report that found that between 1999 and 2015, roughly 20% of the reduction in the men's workforce participation was due to painkiller abuse. One patient in particular comes to mind, a patient that I started working with who, when I started working with him, had gone through treatment for chemical dependency already. The Permanente Medical Group has a specific department for chemical dependency. I work with adult psychiatry on an outpatient basis, not to get you guys too much into the weeds on this thing. But when this person came to me, he was no longer on the opioids per se. He was using them periodically, but he had started his recovery from that process, but was out of work, disconnected from family, and severely depressed. He had lost his business and that he had founded himself, and he was trying to find a way back. And the treatment that was required was months of individual and group psychotherapy so that he was able to completely get off the opioids, for starters, but also to reconnect with his family and to reconnect with his life. He eventually went back to work in the very business that he lost. He ended up selling his business to some friends, and they were good-natured enough to let him return to work at that location, which was very humbling for him because he founded the business, and most people don't want to return to work at a place they founded, as an employee. But, this is what you do to get back. These are, this example is an example of somebody who was in treatment, who had provided who had the resources to get the treatment that he needed. This is not all of the patients we work with. There are many, many people that came to our attention through the Medicaid expansion that were not having any treatment at all, and the only treatment they received at all was through emergency room services when they had crisis situations. In this case, these people were not getting treated at all, and they would just keep coming back periodically. And a lot of my colleagues in the emergency room were aware of this and brought this to my attention. We believe the way forward is emergency services alone are not what is needed for effective treatment. The opioid crisis is also a mental health parity crisis as well. We need better enforcement of mental health parity with medical health, stricter enforcement of existing parity laws. We need more resources for those who've lost the ability to recover. We need more clinicians to help on the ground. This has been something that I've been working on a lot with my colleagues since there's a national shortage of mental health providers. And oftentimes, even with a group like the Permanente Medical Group, which is an excellent employer with excellent benefits, we can't hire all the positions we have. So we have just open positions, and the rest of us have to pick it up, and and that affects our well-being because we're working more hours and have more patients than we have hours to work. So, one last thing I would be remiss if I didn't mention is that my colleagues and I are very frustrated that our pleas have been consistently answered with schemes to provide less and not more service for some of these issues. And we're hoping that we can start to get issues of mental health parity addressed more directly. Thank you.
Thank you. I'm Tim Ryan. It's been hard, and I think Cuyler touched upon it in states like Ohio, and I know this is an epidemic happening everywhere in the country, and we happen to be, unfortunately, in some of the worst shape. But just in the course of a week in my congressional office, last week, you have your staff text chains and email chains. So we get, I think it was maybe Thursday night, we get a picture from my district director, and across the street there are ambulances there, the neighbor with 3 kids overdosed. That same night, I think there were about 18 overdoses in Trumbull County that one night. And there's a bad batch of fentanyl going around. Not that there's a good batch, but a very intense batch that made its way into Trumbull County. I was at a Christmas party, I remember, a holiday party in December, and a friend of mine is a cop in the city of Warren, which is in Trumbull County, and it was probably 10 o'clock at night, and we're sitting there, and we're hanging out, and he pulls out his iPhone, keeps buzzing, and buzzing, and he's in charge of the drug issue really with the Warren PD. And he pulls it out and he shows it to me, and there's 5 or 6 different communications from the coroner. And he said, these are all heroin overdoses right here in our community. And it just keeps happening over and over again. I was touring a school a couple months back in my district, and I remember we didn't even bring it up because we were at the school talking about several other issues, and the principal kept talking about how many parents of kids in the school over the course of the last year or two have overdosed and died. And so it becomes an epidemic in the school. And you have, dozens of kids who have lost parents because of the drug overdose, and many others just overdosed, but maybe their parents didn't pass away. This is how deep this gets into some of our communities. And I know Ken and Jackie and Cuyler, they know this, and I want to thank them for being on the front lines. I see our friends from the Machinists Union that are here for being such a instrumental leader in this. As I'm wrapping up, and I know we got question and answer session too, I just want to say that the debate this week on the Graham-Cassidy bill is front and center on the opiate issue. mean, there's no way you can talk about opiates and overdoses and CARA and CARES Act and all of these things that we're trying to push, and you're going to be pro trying to deal with this epidemic. There is no way you can vote and support the Graham-Cassidy bill. Just to give you an example, the CARES Act gives $1 billion, okay? This was a big achievement in Congress today. $1 billion. The Graham-Cassidy bill takes $9 billion from just the state of Ohio between now and 2026. 200,000 people accessing treatment in Ohio will be thrown off and be told to pull themselves up by their bootstraps. This is unacceptable in the United States of America. We have an epidemic that needs to be dealt with in a comprehensive way, from law enforcement to prevention to treatment to overdose issues, all the way down in a comprehensive way. We have a bill, Congresswoman Marcia Fudge and I, to get rid of the IMD exemption, which means basically if you get federal funding, you can't have a facility that allows more than 16 people if you're dealing with mental health or addiction issues. The recommendation coming from Governor Christie and his team to the president is to provide waivers to the states and make sure that federal money flows so that we can start getting people the kind of treatment that they need. We'll cover more in the Q&A, but I want all of you to know, and anybody within an earshot of this, if you are concerned about this issue, if this is an issue in your state, your congressional district, your community, your school, what's happening with the health care repeal bill today is an atrocity, and it's unacceptable in the United States of America as far as I can tell. Thank you.
So we're now going to open it up to questions. In addition to those in the room, we have quite a few reporters that are watching via the live stream. If any of those that are watching online would like to submit questions, you could do so by sending those via email to questions@press.org. And in addition to those watching on the stream, we have our C-SPAN audience. But if just reporters would submit questions, please. And so the other thing, just one other housekeeping item, if I call on you, if you would please identify your name and your news organization first. So let's start in the back, please.
Thank you. Elizabeth Williamson with the New York Times. I was curious about the 21st Century CARES Act. I was just reading some material from Tom Price at HHS, and he was talking about how he was going to pull back or at least think about the second round of funding and subject it to different criteria. Are you familiar with this or what's happening? I've asked them, and they're going to get me an answer, but I'm curious about that.
I have not heard.
It's supposed to be about $485 million.
I have not heard. I can just say that there is a level of frustration with the administration right now, as I articulated a little bit on the health care bill, that the president said this is going to be deemed an emergency, but yet that's just what he said. Nothing has happened since then. And really all he has to do is tell Secretary Price to implement this as an emergency. And, you know, again, I'm not here to get political. I'm here to stand up for the people in Ohio who are asking for some help here from the federal government. He was in Ohio campaigning, talking about these issues, New Hampshire as well. I remember hearing that this was going to be a priority for him, and here we are. It's almost October, and we're not getting the kind of help that we need. And to be supporting, as the president has, the health care bill and the Rose Garden a few months back, same kind of deal. Hundreds of thousands of people just in Ohio alone, millions of people across the country that wouldn't get the kind of services that they need. So there's a very high level of frustration with some of us. I can maybe speak a little bit louder and clearer than some would like to, others that would probably like to. So we're frustrated, and that wouldn't surprise me if there was all of a sudden some kind of change or pullback, but I don't have any details.
Yes, please. No, I'm in the back. Yes, the microphone.
Yes, thank you, Eric Garcia. Roll call. This one's for Congressman Ryan as well. You know, the president has negotiated with Senate Majority Leader and House Minority Leader Nancy Pelosi about things with debt limit. Have you at all had any frustration that they haven't been able to come to a similar resolution with things like the opioid crisis, the opioid epidemic?
I think that was a good first step. And what I've been saying to everyone, and I think it's appropriate for us to have these kind of conversations. That's what we get elected to come and do here in Congress, is talk to each other, especially people that you don't necessarily agree with. The debt limit and the Harvey relief was a pretty clear shot. Those are pretty clean bills. You get into the opiate issue, you start talking about money. You start talking about complicated policy initiatives, and you start talking, quite frankly, about healthcare and healthcare reform and the ACA. So that obviously complicates things here in Washington, D.C. And I would just like to make this point. You know, we have, when we see on TV, we see a Category 5 hurricane, we see what's going on in Puerto Rico. These are people that absolutely need the kind of help that the United States can afford to give citizens of its own country. But if you have a similar thing happen that happens over the course of 5 years, that is just as much an emergency as an act of God, people in Washington tend to drop the ball on those initiatives. We can do both. I don't know how you can be living in a state right now that has the level of problems that we have, and you're advocating for throwing people off of their health care. And that's what's happening here. So I'm not confident that it's going to happen just because I've been here a while and experiences, tells me otherwise. But I hope that we can continue having these conversations. But here, let me just say this too. There are two clear differences with what we're trying to do with regard to health care in the United States. Obamacare is not perfect. The Affordable Care Act's not perfect. But we were pretty clear in what we wanted to do. We wanted to cover more people, and we wanted to make it more affordable, and we wanted to have rights in there that were activated through the essential benefits package. That's what we wanted to do. The Republican plans, now 3 of them, are throwing people off of health care and making it more expensive, especially with regard to pre-existing conditions. So it's hard to have a negotiation when you have 2 completely fundamental differences as to what you're trying to achieve. And that's what makes the negotiations hard. Bob.
Okay. Hi, Bob Weiner. I'm on Jamie's committee here at the Press Club, and as a member and also former spokesman for the White House Office of National Drug Control Policy and the House Narcotics Committee. I was communications director, and write op-eds. So, a couple quick questions. Because Jamie, I promise you it'd be quick. And especially with your phenomenal panel that you organized here. Congratulations on an amazing, timely, and wonderful event.
It's getting longer.
Yeah, I had to say that, though. It's because it's true what you've done today. So, to follow up on what you've all said, how is treatment going under the Affordable Care Act and the parity legislation? Why, if that stays, which we hope that it would, if that stays, why isn't it enough to cover the gaps that we have in treatment? Why isn't it enough to provide the treatment and to provide the same parity for mental and drug abuse as for physical health? Second, what about legalization and the culture? Is that one of the reasons, and it's something I don't know that I have an answer for, but is that one of the reasons when you throw that out there and half the states have now put some form of it together that makes it more difficult and justifies the use of all drugs, including opiates?
Anybody want to? I mean, there were 2 questions there. One had to do with legalization. One had to do with parity.
And why it isn't sufficient under the Affordable Care Act to actually cover this now?
Well, I just want to comment on that first question, is that, this is a crisis, right? And so although there has been some improvements around mental health parity, but it's not enough, right? We see that in our day-to-day workings. I see that every day at work. We have a long line of folks that want to get in for treatment, And I don't think we really have gotten to the issue of mental health parity and adequate treatment around substance abuse.
I also want to comment on that first question related to, the issue with parity is enforcement. That, within my working for the Permanente Medical Group, this was a significant issue for us in past years. And they're now in compliance with Department of Managed Healthcare policies related to parity. But they, for a long time, weren't, and a lot of their competitors aren't, frankly. So if these things are not being enforced, then it's a big problem. And getting that enforcement to take place in a balanced way is very important.
And then one other thing I'd like to touch base on regarding the Medicaid coverage. My clients that I deal with that are incarcerated, they lose those benefits when they're incarcerated. So when they come out and reintegrate with us before we can, we have them up for a period of 6 months. We have to re-enroll them into Medicaid. Okay, there's some things that they have to do, and we guide them through that as well. But there's also income restrictions also. So if they're working part-time or a full-time at a low wage, they may be making too much money to even get that Medicaid benefit. Okay, and they won't, so then we want to get them into the ACA. But it's a process.
The impact of legalization on the culture and jacking up the numbers.
When you say legalization, I'm not sure what you mean.
half the states have legalized marijuana either recreationally or as a medical quote-unquote device.
Oh, okay. So you're talking about the legalization of marijuana.
And the impact overall on the drug issue and justifying its use in people's minds.
When I was growing up, they often described cannabis as a gateway drug. In some of the clinical work I've done, I've actually seen it sort of in reverse, that when people are trying to get off of the opioids and the stronger substances, they will turn to cannabis. But I don't have meaningful information in terms of the impact or what that would have or not have based upon the opioid epidemic specifically. This is a problem that is not just a problem with illegal drugs, but also a problem with prescription abuse. And that's a significant issue. And there's a recent Sacramento Bee article where there are some counties in California that there are more prescriptions than people in these counties for these kinds of medications.
Yes, please.
Hi, Gloria Gonzalez with Business Insurance. Just to follow up on your last point, some of the issues that we're seeing emanate in the workers' comp field where injured workers are being prescribed opioids. I wonder if you could address that specifically and whether or not there could be some type of legislative fix. I know the state is workers' comp is a state issue, but is there anything that the federal government can do to address that particular issue?
I think that there have been some strides taken in controls in terms of how doctors prescribe the medication. And, when I talk to primary care physicians, they often talk about the restrictions, that it's not just a free-for-all. And I've seen a real change in this. When 10 years ago, people would have prescribed these medications in large doses without many questions. But I'm finding that last few years that there's been a significant shift in that sort of thing. In terms of the legislative end of it, I'm not sure.
Did you want to weigh in on that, or?
And one of the things we've tried to do and promote is through medical schools, beginning to further educate doctors, improve education with regard to the guidelines, limiting prescriptions to 7 days, those kinds of things. I think there's also an opportunity for us to look at, when it comes to chronic pain, alternative ways to dealing with pain. There is a variety of other alternative techniques that I think we need to embrace before we start pushing a lot of the heavy narcotics that have caused a lot of these problems, and in educating doctors and healthcare professionals on how to understand those alternative techniques and then also promote them as well.
I'd like to ask one question before we go back to the floor. in talking to some reporters there in the room, there seems to be an unevenness to the way mental health is offered around the country. Are there some places that are doing better than others, whether it's states or specific programs or pilot programs or partnerships or anything of that nature? That any of you want to comment? Is there some good models there to look at right now?
Now's when you brag.
Well, the Permanente Medical Group's model is a great model, but we just don't have the numbers. We need more people, and it's been a real challenge. I mean, and it was interesting because for a long time there was a reluctance to hire. So, it's with great irony that when the parity issue became very important to the Permanente Medical Group, it became a situation where there just simply weren't the people. And that's, kind of a surprising thing from our end.
I also just want to speak a little bit about the work that we do with young babies, and that our program is unique in that we're able to begin treatment with the parents while they're in custody, start evidence-based treatment, parent-child therapy, infant-parent psychotherapy. And so to me, that's innovative, and I'm wondering why that's not happening in other places, because you're able to begin treatment while a parent's in custody, help them on the reentry, and help their babies as well, and give them specialized treatment, infant development work as well.
Thank you. I think the biggest and most important thing I think we can do is have this done in a comprehensive way, whether you're talking about babies and then using that as an opportunity to get with parents when we're talking about mental health issues, the comorbidity issue of both depression and addiction, and how those all fit together. I think it's important to see the big picture, and I also think it's important that in our schools we start playing offense a little bit with some of this. There are a lot of phenomenal social and emotional learning programs that are showing having significant impacts on these kids and dealing with their social and emotional issues. And you look at what I mentioned a little bit about the schools and some of these things these kids are dealing with at a very early age. They're in violent households, many of them. They're in violent neighborhoods. There's a lot of economic insecurity that's out there that we need to start teaching our young people how to handle these very, very high levels of stress. And I think Jackie mentioned earlier the adverse childhood experiences that these kids are having at a very young age. They have a significant impact as they're happening, but we're finding out more and learning more that even 10, 15, 20, 30 years down the line, that these adverse childhood experiences are affecting their health and costing us a lot of money. And so teaching these kids in school how to handle very complicated lives and very complicated scenarios is really, really important. It's a great investment for us in the long term because we see the costs. We're sitting here talking about tens of billions of dollars and hundreds of billions of dollars over the course of the next decade or two. And some of that should be an investment early on in teaching our kids how to help themselves in ways that are a little more healthier.
We have time for a couple more questions. Yes, sir.
Thanks, Jamie. Will Watson. I'm a member of the National Press Club and a news producer with KBLU Radio. Most of you on the panel are dealing with the opioid issue from the back end. In other words, after the dependencies are taking place. I would like to ask, and Dr. Rogers, you mentioned it, and Congressman Ryan, you mentioned it too. There are growing pushes out there to try and deal with this on the front end. I know there's an organization in your home state, the Society for Opioid-Free Anesthesia. I think it's created by your nurse anesthetists out there to try and come up with new pain blockers so they don't have to use opioids as a companion to anesthesia. CVS pharmacies just announced last week that they're going to restrict the number of opioid pills that are dispensed to people who have trauma or post-surgery. Is Congress working on this? Is there something that you guys can do on the Hill to try and help push the front end of this to close the door on the back end?
Again, I appreciate that because I think that's a huge point. But again, you're talking about research money, and we're seeing budgets come through Congress that aren't very generous. And this has been a trend that's been going on now for, I think, 15 or 20 years. We were able to stem the tide a little bit with the Recovery Act, with the stimulus bill, where we tried to bump up NIH funding to try to make up some lost ground. But these are things that we have to continue to research and encourage the private sector, too, to help encourage and research some of these medications. And then again, begin to train. There are a lot of mindfulness-based approaches when you're talking about dealing with chronic pain, acupuncture, some of these things that people don't get reimbursed. I think Kaiser is on the cutting edge of a lot of these things, but a lot of these techniques that would help, there's no reimbursement, which doesn't necessarily encourage more people going into those fields, but they're starting to show signs of a lot of success. Mindfulness-based relapse prevention, for example, that helps with the comorbidity issue and the depression issue, where 12 weeks after a mindfulness-based program, you're seeing 80% of the people feeling a lot better about things, and even up to a year later, having been able to tame their addiction. They begin to understand some of the deeper things that are causing the addiction, which I think is ultimately what we want to get to. We want to get to the deeper understanding of why people are trying to numb the pain or whatever it is, maybe as a part of the prevention issue too. But this takes resources. I mean, this is the thing that really gets frustrating here, is that we're a wealthy country. We don't want to waste money. We do need to make the government run more efficiently. But when we have problems in the country, we need to come together and begin to solve them. And that means research, and that means not all the research is going to pan out. I think there's a general consensus now, at least with the governing party, that everything you research is you're supposed to have a week later some product there that you're going to be able to show everybody, look what happened. Much of this research maybe not present itself all the benefits right away, but over time, people build on that research that looks like it didn't have any benefit. But it takes time to do that. It takes resources to do that. And I think it takes a general acceptance by the country and the people of the country and the leaders in the country that it's worthwhile. And we have ample examples of how that could be the case, especially faced with an epidemic here that's costing us hundreds of billions, $700 billion. That's pretty significant. So to say we need to bump the NIH budget by a few $1 billion to try to solve this problem, I think most people would say that's a reasonable investment for us to make.
Hi, Cindy Laycox with Leaders Edge magazine. I was wondering if anyone could talk a little bit more about the effect on the workforce. I think you mentioned the drop, and also if there is a role for employers to play in helping with this, especially as you think about the workers' comp setting and all that.
Complicated question, because employers are different in terms of how they handle these situations. There are some protections for people who have a substance abuse issue. They can turn to their employer and say, look, and they get out in terms of FMLA and that sort of thing. But for some of the more longer-term treatment, it becomes very challenging. I don't really have a good response for that, but we're certainly, it's something that we see on the ground level quite a bit, that one of the primary ways that people with these addictions and the underlying problems that lead to the addictions, that it affects their work tremendously. And quite often they do lose their jobs. They just do, because they don't show up, even past the point of their intervention and treatment.
I know we just want to say something.
Yeah, a lot of companies, they have employee benefit packages that include EAP, and so they will get them in and offer them to get into some treatment and what have you. But eventually, if their changes aren't made, they will lose their jobs. Okay, and I don't know what the dollar amount is in lost productivity, but it does add up. Yeah.
We'll take one last question, please. If you could identify yourself.
I'm Jean Gossman. I'm a freelancer, and I'm covering this for the NPC Wire. Dr. Rogers, you mentioned not enough personnel to treat these issues, and can you speak to that? I'm sure salaries are an issue, but is there an insufficient number of people coming through the medical education pipeline? Is it the sheer numbers of patients who are presenting? Can you speak a little bit more about that, please?
Absolutely. The problem is that from treatment of most of these conditions, it requires advanced education. And traditionally, this education is underfunded and there isn't compensation from the employer for past college dues, college debt accrued. Some of the medical programs, they have, loan repayment programs and reimbursement programs for the medical school costs. These just don't exist for a lot of the psychiatric services, especially with chemical dependency. And in terms of the number of providers, it's just there just aren't enough because of that aspect of it. I think it's less a salary issue per se in terms of these providers aren't being provided enough. Although I will say, for some of the support staff, the salary issues become significant. But really the failure for reimbursement on educational costs has been a significant issue for mental health folks.
Well, I think we're about to wrap it up, and I started out this news conference by giving you a sense of how we come up with ideas for newsmakers and how we make these things work. One of the things that I didn't mention is that we actually don't compensate speakers at the press club for traveling from California or Ohio or even Capitol Hill. But what we do is we give each of them one of these valuable press club mugs, which I'm sure more than makes up for it. So we have one of these for each of you. But as for now, we want to thank all of you for coming. It was a very good discussion, and I think we'll all have to watch where this healthcare debate and this question of parity goes from here. Thank you.